Alpha-lipoic acid gets introduced online as the antioxidant that does everything: energy, detox, blood sugar, nerves, aging. Is the honest version that broad, or is there one place where the evidence actually concentrates?
The honest version is narrower and more interesting. Lipoic acid is real biology. It is attached to mitochondrial enzyme complexes that help move carbon from carbohydrates and some amino acids into energy pathways. But a capsule is not simply replacing a missing vitamin. Supplemental ALA creates a temporary pharmacologic exposure with redox effects and signaling effects that may or may not translate into symptoms people can feel. That distinction matters because oral ALA is variable. Food can change absorption, different products use different forms, and the blood level rises and falls rather than staying constant. So if someone says, "I take ALA, therefore my mitochondria are repaired," they skip the hardest part, showing a measurable clinical effect in the right population.
When labels say R-alpha-lipoic acid, stabilized R-ALA, or just alpha-lipoic acid, should viewers treat those as equivalent? And if a trial used one form, can we borrow the result for every bottle?
No, not perfectly. The R form is the naturally occurring enantiomer attached in enzyme systems, while many supplements historically used a mixed RS product. Stabilized R products try to address practical chemistry issues, but the key rule is evidence matching. Dose, route, duration, and formulation are part of the intervention. A label that sounds more advanced is not automatically the proven one.
So let's name the best case. For diabetic peripheral neuropathy, are we talking about nerve repair, pain relief, burning and tingling improvement, or just small questionnaire changes that may not matter day to day?
The strongest signal is symptom improvement, not a proven cure. Meta-analyses of randomized trials in diabetic neuropathy report improvements in total symptom scores, especially paresthesia, burning, numbness, and pain-related measures, often around 600 milligrams per day in the analyzed studies. But nerve conduction and long-term glycemic outcomes are much less convincing. So the practical promise is adjunct symptom management, not reversing diabetes nerve damage. Another reason the claims get messy is route. Some older neuropathy work used intravenous ALA, which is not the same practical intervention as buying oral capsules. Oral trials still matter, but you cannot casually transfer the magnitude from an IV protocol to a shelf product. Route changes exposure, and exposure changes what result is plausible.
If the best fit user often has diabetes, that's exactly where I get nervous. Could ALA stack with insulin, sulfonylureas, or other glucose-lowering medicines and push someone too low?
Yes, ALA may lower blood glucose, so the main practical risk is additive hypoglycemia when it is layered onto diabetes medication without a plan. People using insulin or insulin secretagogues should involve their clinician and monitor more closely if they start it. There are also rare reports of insulin autoimmune syndrome, which is uncommon but important enough that unexplained low glucose after starting ALA should not be brushed off.
What about people without neuropathy who are chasing blood sugar, weight, or cholesterol benefits? Some meta-analyses sound positive, but are those changes big enough to justify making ALA a general cardiometabolic supplement?
The cardiometabolic data are interesting, but not a slam dunk. A large recent meta-analysis found average reductions in fasting glucose, insulin resistance, weight, waist circumference, triglycerides, and HbA1c, but the sizes were generally modest. For example, body weight changed by less than a kilogram on average, and LDL, HDL, and blood pressure were not clearly improved. That argues against using it as a substitute for nutrition, activity, sleep, or prescribed medication. NAFLD is a good reality check. It is tempting to say oxidative stress is involved, ALA is an antioxidant, therefore liver markers should improve. But a 2026 meta-analysis of 7 randomized trials in NAFLD found no significant improvement in liver enzymes, lipids, glycemic indices, adipocytokines, or obesity measures. Mechanism plausibility did not become clinical benefit there.
That seems like the big teaching point. Antioxidant chemistry is not the same as an antioxidant outcome. Does the same caution apply to altitude sickness, heart disease, oxidative stress, IVF media, migraine, and other places ALA gets mentioned?
Exactly. Antioxidant studies are condition-specific. In acute mountain sickness, pooled antioxidant treatment showed a non-significant trend, not proven protection. In coronary artery disease, trials suggest some antioxidants can lower oxidative stress markers, but interventions and biomarkers vary. In IVF media, adding an antioxidant mix that included ALA did not improve fresh pregnancy or live birth rates. Migraine evidence is mostly about omega-3, with ALA still needing stronger confirmation.
If someone with diabetic neuropathy and clinician approval tries it, what should they actually track? Because "I feel healthier" is too vague, and nerves can fluctuate from glucose, shoes, sleep, or activity.
I would define the target before starting: burning pain, tingling, numbness, sleep disruption, or walking tolerance. Use a simple 0 to 10 scale several days per week, keep diabetes care stable, and look for a meaningful pattern rather than one good day. If there is no clear symptom improvement after a fair trial at a studied dose, expectations should change. Do not keep adding supplements to rescue a weak signal. Tolerability is usually not dramatic, but it is real. Nausea, vomiting, abdominal discomfort, headache, and rash are reported. New skin reactions deserve attention because supplements and cosmetic formulations can contribute to allergic contact dermatitis, and ALA has appeared among emerging antioxidant sensitizers. Natural does not mean non-allergenic.
Who should pause before self-experimenting besides people on diabetes medicines? I have heard thyroid medication, pregnancy, breastfeeding, heavy alcohol use, and thiamine deficiency come up. Are those real boundaries?
Yes, those are not internet trivia. They are practical screening points. People taking thyroid treatment should ask their clinician because interactions have been discussed. Pregnancy and breastfeeding are times to avoid casual pharmacologic supplement experiments unless specifically advised. Heavy alcohol use raises concern because thiamine deficiency can be present, and thiamine status matters before ALA. The supplement decision should fit the person, not just the headline benefit. My bottom line is, respect ALA's biology, but do not inflate it. It is a mitochondrial cofactor and a redox active compound. That does not make it a universal energy, detox, liver, fertility, or longevity supplement. The most defensible use is a monitored adjunct trial for diabetic neuropathy symptoms, especially when the product, dose, and expectations match the evidence. If the goal is general wellness, the case gets much thinner.